Okay. All right. So we're going to be talking about suicide and non-suicidal self-injury. What we're talking about now is coming from your psych mental health nursing book. Yes, it is. Psych and mental health nursing, chapter 25. That's what I'm looking at. I'm going to do this a little different. I'm not going to do the concept analysis diagram because I do kind of like the PowerPoint that goes along with this. So we will be sharing the screen and looking at the PowerPoint, not just the concept. So I'm going to share my screen. All right. So some objectives of this chapter: summarize the profile of suicide in the U.S. What are some risk factors? What are risk factors for suicide, including what coexisting psychiatric disorders? And if you'll remember, it hasn't been that long ago before we talked about bipolar and we talked about depressive disorder. Both of those put you at risk. And if you know which one is the worst, can you remember which one I said is more likely to commit suicide? If you're manic or depressive, what end of the bipolar spectrum is most likely? It was the mania, the manic part. All right, so what's the definition of suicide? That is the intentional act of killing yourself, of killing oneself by any means. I don't think we have to spell that out, right? By taking pills, you can overdose, you can shoot yourself. One thing the book talks about says it's hard to determine exactly how much suicide there is because a lot of people choose to end their life by like driving off a bridge, driving over a cliff. A lot of those may be classified as accidental when they maybe were actually suicide. So, we don't know for sure what the percentage is of completed suicides that we have. So suicidal ideation, of course, is you're thinking about killing yourself, and a completed suicide is a suicide attempt that successfully results in your death. Non-suicidal self-injury. So when we're talking about that, the biggest thing now that you can probably understand is cutting. A lot of people cut. They'll cut their arms or they'll cut their legs. That's the self-injury directed at the surface of the body to induce relief. It's a release of stress. They're in stress and it makes them feel better. It releases that stress to cut themselves. Or, what are some others? There's probably plenty of other type of injury. It's just that's the one that I think is really going on now in the US that we hear about. All right, so before we go into the epidemiology here, go back and look at your book. Let me tell you where I'm at. I'm still under suicide. Turn the page. It says in the year before their deaths, 83% of individuals were seen by a healthcare professional. 54% of those who died by suicide did not have a mental health diagnosis. So we did talk about the pre-existing conditions of bipolar disorder, depressive disorder, but this says 54% of those who die by suicide don't have any of those conditions. This says approximately 50% of patients who died by suicide made a healthcare visit within 1 month of their death. So let's just talk about that. With that being said, remember we talked about when we were just talking about depression, that all the providers should be doing this depression scale. Every time they come see you, they should be screening you for depression. This is one of the reasons, because they want to catch any thoughts of suicide. So look at this epidemiology down here. 47,000 people died in 2017 by suicide. Do you think that number has gone up or down for 2023? What do you think COVID and all that shut-in and isolation has done to people? I'd be interested. I don't know the answer. I would be interested to look and see what the current suicide rate is. All right, so again, this talks about the comorbidity. If you do have a current psychiatric disorder, that's a risk factor. Major depressive disorder, substance use, and psychosis are the diagnoses that are most commonly associated with suicide, and would be those three. Just look at this suicide facts box. And of course, it's 2017 because that's the last complete statistics this book got. So just look at the general, but then look at gender statistics. Men died by suicide more often than women. Remember, I told you more women attempt suicide, but more men are successful at completing suicide. It says white men accounted for 70% of all suicide deaths. But anyway, the gender statistics are the main thing I want you to look at from there. That's just a good basis for what you need to know. Look at what's going on with our armed forces from the PowerPoint. Suicide rates among active duty service members is more than civilian rates. That's amazing, because what percentage of population in the US is in active duty military? So that's really significant. And suicide rates among veterans, the ones that have gotten out of the military, are increasing more rapidly than that of the general population. And they have the PTSD going on. That's another comorbidity, or would be a risk factor. A lot of people that have been in wars have seen things that probably nobody should ever have to see. So they are definitely at an increased risk. What about transgender? This case study is a transgender youth, but what about transgenders of any age? Do you think that's easy to be transgender? So let's look at this. Gino, who is 14, identifies as transgender. Says, I have known since I was real little that I was meant to be a girl. I'm a girl on the inside and always have been. As soon as I'm of age, I'm going to get surgery for gender reassignment. I've been saving my money for it as long as I can remember. In the meantime, she asked her friends to call her Gina instead of Gino. Says, I grew up with these same kids, so with my friends, it's really no big deal. This year, however, things have changed a bit for Gina. Growing up in a small neighborhood school in the city, she has now entered a new, larger school. And we're still talking about in the city, and she's beginning to get pushed around in the halls. Recently, Gina, who dresses and grooms herself as a girl, so, makeup, shaving, that's dresses, went to use the girls' bathroom, which was allowed at the private school. And the teacher followed her in and shooed her back out, calling her disgusting. So she's moved from one totally accepted place to one where now she is not as accepted. So looking at that case study, what are some risk factors you can identify here? Let's see if we can recognize some problems. Okay, so first off, what about the age? 14, adolescence. Is that a risk factor in and of itself? So there's age. Transgender, that's a huge risk factor because of acceptance or lack of acceptance from the family or the community. Move into another school. That's stress for any kid. So you can imagine the increased stress it would be for a transgender. Being pushed around in the halls, is that another important thing to recognize? The teacher calling her disgusting. Again, we're 14. How do you think Gina feels at this point? Do you think she's got any kind of coping mechanisms that would help with that? That just seems like a big problem. No matter how you feel about transgender, you can still see for this 14-year-old kid, I would expect you could have some empathy for that. So this case study is talking about, what may put her at risk for suicide because she has all these stresses dumped on her all at once. All right, so risk factors. Psychiatric disorders, we already talked about that. Alcohol or substance use disorders. Male, increasing age the older you get. Race, and again, I think it's interesting to note 85 to 90% of completed suicides are Caucasian. Religion, now I don't know what type of religion that's supposed to be. I don't think the book says anything. I'm curious about that though. It just says cultural and religious beliefs. That may be a belief that suicide is a noble resolution of a personal dilemma. I guess maybe if you're Catholic and you're gay, that's a personal dilemma. According to the church, you might feel like suicide's a way to get out of that. Marriage, single people more likely than married people. Profession. Let's see, what does it say about profession? Should be here under societal factors. Well, I just don't see it right off what it talks about profession. In physical health, if you're in poor physical health, you're more likely to want to commit suicide. I do want you to look at from the book under social factors, because this is something I think is definitely worthy to be talking about this day and age, and that is social media. Says social media have led to the rapid spread of messages about suicide, both positive and negative. We know there are some of these challenges, the TikTok challenges that go around, and kids are committing suicide while on video. And we also know since COVID and we were all isolated and shut down, now more people than ever are using social media, and not just kids, but also adults. So anyway, it just says the impact of social media on suicide prevention is worthy of further study, because it does have an impact on suicide. So suicide prevention would be something worthy to look at. Biological factors. There is a familial tendency. It may run in the family. Could be genetic. Low serotonin levels. And what other disorder does that happen in? It's a neurotransmitter we talked about in the previous chapter. Major depressive disorder. All right, so here's talking about some psychosocial factors and some theories. So Freud, I'm not a big believer in Freud, but he does have a theory that it's aggression turned inward towards yourself. Meninger's 3 parts to suicide. Aaron Beck says the central factor is hopelessness, stress, suicidal fantasies. If I kill myself, or, what about some of these people that want to attempt suicide for the attention, and then they accidentally really die? I mean, just a lot of things going on. So LGBT, and we know now it's QIA plus. Youth and bullying. So this kind of goes back to that case study of Gina we were just looking at. Bisexual females are more likely to be bullied than heterosexuals. Sexual minority youth, and again, that's your LGBTQIA plus, are more likely to report suicidal ideation. Maybe I'll just be better off if I'm dead. Thinking along those lines. And then it talks about some cultural factors. Do you remember culturally, maybe not so much culturally, but demographically, what ethnicity is more likely to commit suicide? Or what race, should I say, not ethnicity, race. And that was that Caucasian male. All right, protective factors. So if you look at some protective factors, that's in the book. These are protective factors, are factors that kind of help you to not commit suicide, why these people would be less likely to commit suicide. So African Americans, they tend to have stronger religious roots, and a very big and close extended family. Hispanic Americans, not all of them, but the majority of them are Catholic. Important again for that extended family there. And then Asian Americans, their adherence to religion, and in education, they're just so driven for the most part, not all of them stereotypically. So those are some protective factors that make them less likely to commit suicide. All right, societal factors. And see, this is why I don't like going by the slides because I keep having to go back and forth in the book because it's never in line. But societal factors, let's look at assisted suicide. It says in the US, individual states can allow, regulate, or prohibit assisted suicide. What is assisted suicide? Is it the same as euthanasia? It is not. So assisted suicide is where I tell the doctor I want to kill myself. Of course, normally this is going to be if I have a chronic illness of which I'm not expected to get better, that I would like to ease myself on out. So the physician may prescribe for me, provide a prescription for a lot of morphine, a lot of medication that if I take too many, it'll depress my respirations, and then I will die. So assisted suicide means they give me the means to kill myself, but they don't actually give me the medicine. They just give me that prescription so that I can go and do it myself. Euthanasia, on the other hand, means that they are literally giving me an injection of something that will kill me. So that's your difference between assisted suicide and euthanasia. So clinical picture, see, and this goes back in the book from where we were. Risk assessment. Do they have a history of suicide attempts? If they do, that increases their risk of a successful one. Suicide behavior disorder, if they have attempted suicide within the last 2 years, when they were in their right mind, was in a state of confusion or delirium, and not undertaking for a political objective, like I'm going to make a statement. So that is your criteria for suicide behavior disorder. All right, so let's look at assessment, verbal and nonverbal cues. So you remember verbal communication is anything that comes out of my mouth and also anything that is written. Words, those are verbal. Nonverbal, I'm standing here with my arms crossed, my hands on my hips. My voice is very loud and mean. That's some nonverbal communication. I just want you to remember that. So let's look at this. Some overt statements, and this is from the book. If they tell you life isn't worth living, I wish I were dead, everybody would be better off if I died. Those are overt. That is them crying out for help. They're letting you know they are thinking about committing suicide. Covert statements and nonverbal clues. What if they say, it's okay now, soon everything's going to be just fine. I won't be a problem for you much longer. You know, what if they start giving away their prized possessions? That would be a clue also. So turn the page. And it talks about some specific questions we need to ask about suicidal ideation. And look at the bullet points. You know, what you want to know is, have you ever felt like committing suicide? Have you thought about it? Have you attempted it? Do you have a plan? And if so, what is your plan? And you can't feel weird asking about that. I mean, you need to know you could be potentially saving somebody's life. Down here from the book says the nurse should be alert for nonverbal behavior clues. And this is, they have been feeling really bad and depressed, and all of a sudden they're just feeling really good, giving away possessions, writing letters, What if they make a will? It says individuals may be at greater risk as their mood lifts because they have enough energy to act on their feelings of ambivalence regarding suicide. And I want you to relate that back to what I said about manic depression. They're more likely to commit suicide in the manic phase when they have the energy. So remember that. It's hard for us to do a discussion question with me in the room by myself. So I'm not going to do this. All right, self-assessment. And I do want you to look at this assessment guidelines, this little orangish box down here. And again, look at number 4, because that's something we just talked about. So healthcare professionals working with individuals who have suicidal ideation, we need some place to express our thoughts and feelings as well. You know, what if our patient does commit suicide? You know, how would you feel? If you have a real strong religious background that's very much against suicide and you have a patient that comes in that tried to commit suicide, how would you feel? How would you act? Remember, no matter what, we have to be non-judgmental towards these patients. It is not our job to judge. It's our job to treat them holistically with the dignity afforded any human being on this earth. All right, so I'm going to be going back to the book. All right, it's going to talk about some interventions we have. I'm not in the book. Hold on. All right, I want you to look at this Malu therapy. It's on my page 479. What is Malu therapy? It's an interprofessional approach that emphasizes communication involving a lot of different professionals, social workers, therapists, nurses, counselors. It's a collaborative approach to this acute care of that suicidal patient. So, what are some prevention activities that provide support, information, and education to prevent suicide? What would some of those activities be? So, I mean, we have the suicide hotline. You have it commercials running a lot about if you feel depressed or suicidal, contact these people. What can you do in the school? Can you have professionals come talk to these school-age kids? I think that would be very well received and successful. So treatment of that actual suicidal crisis, whether they have attempted it or about to attempt it, you know, that's where we can put them in that 72-hour hold where they cannot leave AMA because they are a threat to themselves. And then postvention are interventions with a circle of survivors. So how do you think these suicide survivors feel? You know, somebody may commit suicide thinking it's going to make everybody's life much easier because they're a real mess up in life and, you know, they can't do anything right. So they'll just kill themselves. So they do. How do you think that leaves their parents and spouse and kids? So that's what we're talking about with the suicide survivors. That's the survivors of a person who has successfully committed suicide. And this gives you some, some of these in italics. There are several little notes here, some excerpts from letters written from parents, I think mostly written to their children that have committed suicide. Very, very touching. I would read those if I were you. All right. So interventions here and treatment modalities. And again, I am in the book. So pharmacotherapy. There is no drug that helps prevent suicide. But there are drugs that can help even out the depressive disorder or the bipolar disorders, right? So that's what it's talking about with the pharmacotherapy, making sure they are taking their meds for any comorbid. Brain stimulant treatment. So we know that takes effect immediately. But again, you would have to know, they would have to have let somebody know they're about to commit suicide. And then you take them in for that 72-hour hold and get them to treatment. So there has to have been a lot of things that happened before you can do that. And psychological, this is going to be a psychiatrist, a counselor, a psychologist. You have to really, really document this care big time. When they are in your care and they are post-suicide attempt, like I was stating earlier, you have to put them in a room. You have to have somebody in that room with them all the time. Here's some of these environmental safety guidelines I was talking about. The door has to be open at all times. They can't have those call lights because you don't want them having any cords. You have to have that room bare bones, nothing that they can hurt themselves with while they're in your care. And, like I said, all the hospitals do have one room that will meet all that criteria. Oh, here's Gina. Sorry. Here's Gina again. Let's see what's going on with her. So she is hospitalized for suicidal ideation after 2 suicide attempts. For her first 2 days of hospitalization, she eats 20% of her meals and stays in her room between the group therapy. By the 4th day, the nurse observes that the patient is more sociable, is eating meals, and has a bright affect. So what would that mean? What would you think about Gina? Does anything jump out at you here? Let's look at what are some of the cues that we're recognizing. So what jumps out at me is that all of a sudden she becomes sociable and starts eating her food and has a bright affect. What have studies shown could happen once they start feeling a lot better? That's when they could commit suicide, right? All right, so our non-suicidal self-injury. Again, intentional damage to your body tissue. You don't want to kill yourself. So I was talking about cutting earlier, but this says minor behaviors. How many people have never picked off a scab? But I guess this is considered a minor behavior, biting your fingernails. A lot of kids bite their fingernails. So sometimes they can achieve a state of euphoria through this self-injurious behavior. Okay, risk factors for this. And I want you to see that a lot of this is talking about youth, because this has really become an issue with the adolescents, especially adolescent girls. And then it talks about application of the nursing process along with this. Let's just look at importance of empathy. Remember that empathy is totally separate and different from sympathy. Empathy is I'm trying to understand where you're coming from. Sympathy is I'm feeling sorry for you. Those are two totally different things. Important to develop empathy. Now, is that something you can develop if you don't have it? I mean, you have to really be able to connect with people to feel empathy, and that is something you need to work on. This just talks a little bit more about application of the nursing process, the planning, interventions, advanced interventions, and evaluation. Of course, if they're cutting themselves or harming themselves in other ways, psychotherapy, clinical supervision, consultation. A lot of times, if it is a youth, the family will be drawn in to the psychotherapy as well, so that everybody's on the same page. So from this, again, look at all these key points and know them. And I just want to say this out of this book, it's got some good chapter review questions at the end of each chapter. I think it would be good practice for you to go and take these questions, do these questions after you listen to these lectures. And after, because I hope you're going through the book as we are doing the lecture and see kind of where you're at with your knowledge, with your knowledge base, because you are going to be tested over all this stuff. So that is going to be it with our suicide and non-suicidal self-injury. You know what to do if you have any questions.